In this section, I want to talk about the hepatitis viruses. I've kind of alluded to this throughout the virology section, that there really is no family of hepatitis viruses. Instead, the viruses that cause the condition that we call hepatitis all come from different viral groups. Some are RNA, some are DNA. But because they all cause the same symptoms and they target the same organ, we call them the hepatitis viruses. There are at least 6 different viruses known to cause hepatitis, A through E and G. There was one called hepatitis F, if you're doing your alphabet going, she skipped a letter, but it turned out that it was not a real thing. The viruses differ in structure, replication, time course of the disease, etc. So here are the first 5, hepatitis A, B, C, D, and E. I always feel bad for microbiologists, and I am one, so I feel bad for myself, because everything changes all the time. When I was a kid, there was only hepatitis A and hepatitis B. And then all of a sudden, there's all these other hepatitis viruses. I mean, they've been around, but we just didn't know about them. So again, we have the more we learn, the more we can describe different kinds of viruses. So I'm not going to go over this chart right now, but it is here for your reference. It compares the 5 major hepatitis viruses that we'll talk about. Instead, we're going to actually talk about the 5 major types of hepatitis viruses as we go through the next slides. So the first one we'll talk about is hepatitis A. Hepatitis A, you might remember I mentioned a while back, as a member of the P coronaviruses. It is naked. It has a single-stranded positive sense strand RNA genome, and it is very stable. Remember, naked viruses, super, super stable. It is one of the enteroviruses in the P coronavirus group. It is stable to acid, stable to solvents, stable to detergent, stable in water, stable to drying, stable in the refrigerator, stable even at fairly high temperatures. It can be inactivated by chlorine treatment of drinking water, formalin, acid, radiation. Sometimes this is called infectious hepatitis. This is one that you can fairly easily get from another individual through the fecal oral route. And I'm hoping you're going, ew, how do I get a fecal oral virus from other people? Well, when they have it and they prepare your food and they don't have great personal hygiene and then you eat it is generally how we have the spread of hepatitis A. It interacts with receptors on the surface of the liver and T cells. It, even though it's naked, is generally not cytolytic. It's most often released through exocytosis. So basically a bunch of formed viral particles will be extruded through vesicles instead of bursting out of the host cell. Hepatitis A is not associated with causing chronic infection, and it is not associated with causing cancer. So I'm pointing these things out right now because the other hepatitis viruses might be a little bit different. Approximately 40% of hepatitis cases are actually hepatitis A, and it can spread pretty rapidly because people are not aware that they have the infection because they haven't developed symptoms yet. So it can spread in the stool prior to the development of symptoms. And so you would hope, you'd hope that your people preparing your food, wash their hands after they defecate, but okay. But you would hope that once they develop symptoms of hepatitis, they're also not going to work. There's a lot of hope and trust when you go out to eat. Hepatitis A is generally diagnosed based on symptoms and known exposure, and we also have an ELISA to detect hepatitis A specific antibodies. Generally, you'll have a relatively long incubation period. The virus will then be in the blood and in the feces. Some patients will develop icteric symptoms. This is like symptoms of jaundice, right? Hepatitis. And elevated liver enzymes. It is possible, let's say, we'll blame Chipotle because everybody blames Chipotle for everything. So let's say we find out tomorrow that there is a huge outbreak of hepatitis A at Chipotle in Fig Garden. because that's my closest Chipotle. So there's an outbreak of hepatitis at Chipotle Fig Garden, and maybe I ate there yesterday. I didn't, but let's say I did. I could be given preformed hepatitis A antibodies in order to help prevent me from developing hepatitis A. But I wouldn't need that, actually, because there is also a hepatitis A vaccine. The hepatitis A vaccine, it works pretty well. It's based on a killed virus, and this is recommended for every individual because anybody is at risk. So I got this a long time ago, so I know that if they had hepatitis A at Chipotle, I would be super grossed out, but I wouldn't be worried that I would get sick. Hepatitis E, it causes similar symptoms, similar type of disease, but it has a much higher mortality rate. So our major symptoms of either hepatitis A or E are going to be things like nausea, diarrhea, vomiting, potentially, again, those icteric symptoms. But hepatitis E, even though it is a virus that causes very similar symptoms and it's transmitted in a very similar way, it is not a related virus. It is not a member of the P coronaviruses. Even your previous slide, your table says it's in a specific viral group, but it's not even in that group anymore. Again, with all of the molecular advances, we start moving things around. Hepatitis E is one of those that's just been moved around. But we don't have a vaccine for hepatitis E either. So it's less common, but it causes more severe disease with a higher mortality rate. Hepatitis B belongs to a group of viruses called the hepatinoviruses. They're enveloped. This is a DNA-based virus. This causes what is sometimes called serum hepatitis, or we call A, infectious hepatitis. So hepatitis B is bloodborne or sexually transmitted. So as a bloodborne infection, any of you who, again, are going to be planning to work in healthcare, which I imagine is most of you, if you haven't already, you will likely be vaccinated against hepatitis B because of the potential for bloodborne illness. And aside from the fact that you may want to be vaccinated to protect yourself from infection, which is, always recommended, you also want to prevent hepatitis B infection specifically because it can lead to chronic hepatitis, which could eventually progress into hepatocellular carcinoma or liver cancer. Hepatitis B is weird. The hepatoviruses are weird. They have a very unique type of replication among the DNA viruses. Why they do this, we don't know. So what they do, they have a double-stranded DNA genome, so they get into the host cell, the DNA gets into the nucleus, it is transcribed, it is translated, and then some of the RNA that comes out is reverse transcribed back into DNA to be packaged into the viral particles. So I feel like they're taking extra steps here, but this is one of the other viral groups that encodes a reverse transcriptase. So it's a DNA-based genome, gets into the nucleus, does transcription. That mRNA leaves the nucleus. Some of it is used for translation of hepatitis B proteins. Some of the mRNA is used to serve as a template for the synthesis of the genomic DNA. So they use reverse transcriptase to reverse transcribe that RNA into a DNA molecule. It's really weird. These are enveloped viruses, but they are fairly stable for an enveloped virus. So they're not as sensitive as some of our other enveloped viruses. One of the other really weird things that hepatitis B does, aside from, use reverse transcriptase when it doesn't really seem necessary, you're seeing it down here. Hepatitis B throws out what are called antigenic decoys. So yes, from the infected cell, you will have the release of virions. You also have the release of pieces of envelope and proteins that do not contain the full virus. And the point of this, it's actually, I don't know, it's kind of insidious. And you can see it's very effective. It's basically, if you throw out, here they're showing 4 particles. So if you throw out 4 decoys for every 1 virus, the virus has a much better chance of getting into another cell instead of being tangled up with an antibody. So these decoys are basically supposed to engage with the antibodies, allowing the viruses to continue to spread. Sneaky, right? The genome can integrate, which is why you can have that chronic infection, you can have progression to cancer. Hepatitis B is found in blood, saliva, milk, breast milk, semen, amniotic fluid, and vaginal secretions. So that's why it can be transmitted sexually or bloodborne. It will start replicating in liver cells approximately 3 days after infection. And the majority of symptoms are actually thought to be caused by the immune response. So the immune system is targeting hepatitis B infected cells, which leads to the release of liver enzymes and symptoms of jaundice. So in most patients who have effective cell-mediated immune responses, you do get resolution of infection. In some patients, however, maybe they have a limited cell-mediated immune response, something. You can have chronic disease with mild symptoms. So again, if the symptoms are being caused by the immune system working really well, if your immune system is not working really well, you probably wouldn't even notice you have a problem. Maybe you'll have elevated liver enzymes, but when was the last time you went and got your liver enzymes checked? If your eyes turn yellow, you'll notice there's a problem. If they don't, so in patients who have chronic infection with hepatitis B, you eventually can get cirrhosis of the liver. That's most common. You can also develop that hepatocellular carcinoma. And in some cases, you'll have a co-infection with something that is called delta agent. Delta agent is also sometimes known as hepatitis D, which we'll talk about. We're going in alphabetical order. When you have co-infection with hepatitis B and D, you can get what's called fulminant hepatitis. Basically, what this means is that you think you're fine. Everything's fine. No problem. And then your liver fails within days. So this fulminant hepatitis is basically the idea that your liver shuts down really, really quickly when you have this co-infection with delta agent. Cell-mediated immunity and inflammation, of course, cause the symptoms like we talk about, but they also can lead to resolution. So you're probably going to feel worse at first if you have a functional immune system, but you'll end up feeling better later. A decreased T cell response, so a decreased cell-mediated immune response, is what can promote chronic infection. Antibody then can also protect against infection because antibody prevents the virus from spreading and getting into host cells. Children generally have less severe symptoms because they don't have that super functional cell-mediated immune response. So, less severe symptoms, also less able to clear the infection. So, that's bad because 90% of infected infants become chronic carriers. They can't clear it. We can get cellular swelling and necrosis of the liver. So, that's going to be what leads to cirrhosis. If you can clear the infection, the liver is one of those organs that's, takes a beating and it keeps on, keeps on going. What's the saying? It takes a licking and keeps on ticking. The liver is one of those that you can be pretty mean to your liver. And if you stop being mean to your liver will often forgive you. It's like a puppy. You yell at your puppy, you turn around, your puppy will still give you kisses. Your liver will regenerate if it hasn't been damaged beyond the point of repair. So the ability to get this infection diagnosed, if you can eventually clear it, you can regenerate those damaged parts of the liver. Now, when you have fulminant hepatitis, when you have chronic hepatitis, especially when you have that co-infection with delta agent, hepatitis D, that can lead to permanent damage and cirrhosis. So, with cirrhosis, we often associate that with like chronic alcoholism. You can't drink a gallon of vodka a day for 30 years and expect that your liver is going to be like cool when you stop drinking. The same thing here. When you've abused your liver, the virus has abused your liver so much that you have permanent damage and cirrhosis, that then cannot be regenerated. And at that point, we would have to talk about a liver transplant as being the only way to survive. It is estimated that approximately 850,000 people in the US have a chronic infection, 250 plus million worldwide with chronic infection. 15% of the world's population is estimated to be infected during birth or childhood. So here you see in like sub-Saharan Africa, Southeast Asia, a little bit in the South Pacific, we have a really high incidence of liver cancer. We have high prevalence of hepatitis B, and therefore we also have a high prevalence of liver cancer. High-risk groups for hepatitis B include people from endemic areas, China, Africa, Alaska, the Pacific Islands, babies born to mothers with chronic hepatitis B, intravenous drug users, people with multiple sex partners who do not practice safe sex, hemophiliacs and other patients requiring blood products, healthcare personnel who have contact with blood, residents and staff staff members of institutions for people who have developmental delays. This is because in some of those situations, if the residents of one of these institutions are violent, which can sometimes happen. Sometimes these residents can be violent. They can attack each other. They can attack staff members. And unfortunately, in a lot of those institutions, there's also some sexual abuse that can go on. Again, sometimes it's the staff members abusing the residents, or sometimes residents can be very abusive themselves. Hemodialysis patients and blood and organ recipients as well. Here are our major symptoms: jaundice, dark urine, tiredness, loss of appetite, nausea, pain, itching. Some patients will develop a fever, rash, and arthritis, but not a huge amount of patients. An RUQ pain, this means right upper quadrant, so it's kind of where the liver is, so abdominal pain. Acute hepatitis B, the majority of patients, 90%, will resolve the infection. 1% will develop fulminant hepatitis from just that original infection, so it's rare. 9% will become what we call kind of a chronic carrier because they are carrying or producing antigen for more than 6 months. Eventually, 50% of those will resolve it. Some will be asymptomatic carriers. Some will develop chronic persistent hepatitis, which can eventually lead to extrahepatic disease, so especially like affecting the kidneys, or chronic active hepatitis, which can also go extrahepatic but can cause cirrhosis or cancer. So again, 5 to 10% of patients will develop chronic hepatitis B. 1/3 have what we call chronic active with continued liver destruction. So that's what we're seeing here, chronic active, continued liver destruction. 80% of primary hepatic cancers are attributed to chronic hepatitis B. Unfortunately, liver cancer is usually fatal, and it is one of the most common cancer mortalities. So it's not a cancer that maybe we hear a ton about, but it is one that has a very high mortality rate. It can be diagnosed based on symptoms and liver enzymes. Serology can describe a course of infection, so you look for those different antibodies. If a newborn is born to someone known to have hepatitis B, passive immunization within a week of exposure or to a newborn, that can help prevent infection. Treatment with polymerase inhibitors or nucleoside analogs. Of course, our best bet is vaccination, a series of 3 immunizations that will protect you from hepatitis B. So I highly recommend getting vaccinated. Okay, I'm going to go out of alphabetical order. I know that C comes after B, but we just talked about B, so I'm going to talk about D real quick. Hepatitis D is also called Delta agent. It is not considered its own virus technically. It's called a subviral satellite because it cannot replicate unless HBV, so hepatitis B, is also present. It can be transmitted with hepatitis B, which is considered to be a co-infection, or after the original infection with hepatitis B. So basically, with this super infection, what you're talking about is the idea that a patient already had hepatitis B, and then they got exposed again to something that was contaminated with hepatitis B and hepatitis D. So perhaps it was an unsafe sexual practice, some sort of bloodborne issue, whatever. But what happens is, again, with that co-infection or even super infection, you're more likely to develop cirrhosis, chronic infection, and of course that fulminant hepatitis. Okay, so that's hepatitis D. Now we'll go to C. Hepatitis C is a member of the flaviviruses. You might remember I told you, oh, flaviviruses are arboviruses, except hepatitis C. So it's an enveloped positive sense-strand RNA virus. This is the most common cause of what is called, or what was called, non-A, non-B hepatitis. So prior to the discovery or characterization of hepatitis C, people who had hepatitis suspected to be of viral origin but was not caused by hepatitis A or hepatitis B were diagnosed as having non-A, non-B hepatitis. So even when, back in the 80s, 90s, early 90s, were getting non-A, non-B hepatitis. Turns out most of them probably had hepatitis C. It's estimated that there are at least 170 million chronic cases worldwide, approximately 3 million in the US, and annually approximately 17,000 deaths. Transmission is similar to HBV, right? So we're talking about bloodborne, sexually transmitted. However, hepatitis C is more likely to cause chronic infection. And hepatitis C only infects humans and chimpanzees, as far as we know. Generally, what we're looking at with hepatitis C is only approximately 15% of patients are able to recover from the initial infection. Remember, with hepatitis B, we were talking about 90% of patients. 15% will develop rapid cirrhosis. The majority will develop persistent infection. In some, that can fairly quickly progress to chronic hepatitis. So maybe 6 months to a year after infection, they might develop chronic hepatitis. Some patients will remain asymptomatic for a very long time, and some of those may eventually develop chronic hepatitis. And in those patients who develop chronic hepatitis, we often see a significant amount of cirrhosis, some liver failure, and some hepatocellular carcinoma as well. Hepatitis C is diagnosed based on ELISA, or reverse transcriptase PCR, and can be confirmed by Western blot. Interferon, ribavirin, proteases, and polymerase inhibitors are available. Remember, even though hepatitis C does not have that really unique reverse transcriptase, it still is an RNA-based virus. And an RNA-based virus has to have an RNA-dependent RNA polymerase, which is not normal in humans. So if we can inhibit that enzyme, that's very helpful. So we did talk about hepatitis E when we talked about hepatitis A. We talked about hepatitis D when we talked about hepatitis B, so I guess I totally lied about going in alphabetical order. Hepatitis G is not going to get much of a mention from me. There's a debatable role about whether or not it causes disease. Even though it is a member of the Flaviviridae, so it is a flavivirus. It looks like hepatitis C, but they don't know whether or not it actually causes disease, and it kind of got classified into the hepatitis group because of its resemblance to hepatitis C. But when I was reading about it a little bit more recently, my understanding is, and I'm always hesitant to like tell you a firm thing because virus taxonomy is so weird. What I was reading recently is that they've actually decided to potentially rename this virus and not call it hepatitis G anymore because they don't think it actually causes symptoms of hepatitis. But it looks a lot like hepatitis C. So I think right now we can be fairly confident with A through E, and we'll leave it at that.